All right.
Okay.
Starting the timer. Here is the timer and here is the question. Next.
Yes, ma'am. Next, please.
Okay.
Yes, ma'am.
Right.
Yes,
You
ma'am.
have read and you're ready. Kindly begin your station.
Yes, ma'am. Ma'am, can you have this first slide
Yes, please.
on the screen? Yes.
Yes. Begin.
Hello. Good morning.
Hello, good morning.
Good morning, sir. My name is Dr. Ishfaq. I'm one of the doctors working in hospital, the Desh Hospital, under the Desh consultant. I need to speak to CVTS consultant about a patient for the possible transfer who we think is having widened mediastinum. So can I please check that I'm speaking to Mr. Peter?
Yes, I'm Mr. Peter. So could you please summarize your case, doctor?
Okay, thank you. We have a patient, a 23-year-old male who came to us as a history with a history of RTA, has been who came in a bit drowsy condition. On assessment, we came to know that he has a GCS of 14, pulse rate of 120, heart rate of blood pressure of 100 by 80 mm of Hg. His temperature was at that time 37 degree. His hemoglobin, we have done some blood investigations that revealed that his hemoglobin is 8 milligram per deciliter. However, his urea, his kidney function and liver function tests are normal. His CRP is bit raised. We had an ABG that revealed that his pH is 7.32, PaO2 is 100 kilopascals, PaCO2 is 6 kilopascals, and bicarbonate is 19. So on further examination, we observed that he has a left swollen left swollen thigh, and we have done an X-ray and neck canal. Next slide. We have done an X-ray of chest, which has revealed the widened mediastinum with bilateral pillar effusion. We have done also abdominal X-ray standing, that is showing absent source shadow and small bulbs are dilated. The X-ray of the lower limb shows that he is having fracture of left femur, shaft fracture. We have so far we have managed the patient. We have given 4 liters of crystallized fluids, and we have taken blood for cross matching and blood grouping, and we have arranged 6 units of blood, but they are standby. And we have put a chest tube on his right side for this pleural effusion. So we are considering where this in this patient, our main concern is that he is having this widened mediastinum. So if he could be immediately shifted to your, transferred to your center for urgent management.
Okay, so doctor, would you want to do a CT scan of the chest and abdomen?
Yes, we would have done that, but unfortunately, CT is not functional at this time, and it's expected that it won't be functional for the next 3 days. So
Good.
we're thinking we shouldn't be delaying the transfer, and that can be done at your center. That shouldn't delay the transfer process.
What about his cervical spine? How are you planning to manage it?
I don't know whether he's on cervical spine, but as soon as I will get off the phone, I will make sure that he's wearing a cervical spine, and I will let you know about that.
Okay, you said his blood pressure is 100/80. So
Yes,
what are you going to do about this?
So I'm going to give him the fluid challenge. We have already given him 4 liters of crystallites. I'm giving him one more fluid challenge, and we'll see the response and monitor at the same time. And if he's not responding, I may have to consider for the blood transfusion, and I have to contact my consultant and discuss with the blood bank and hematologist before that. And I will let you know after after we came to some decision. I will be updating you about that.
So will you rapidly increase the blood pressure?
No,
Should you do
we
that?
don't want to. We don't want to rapidly increase the blood pressure, because in this patient we are suspecting that patient might be having the widened mediastinum just because of the great vessel injury. And if we increase the blood pressure rapidly, the hematoma which has already been there, which is preventing the further deterioration, further blood loss. So if we increase the blood pressure rapidly, that can dislodge the clot and patient can deteriorate suddenly. So we will keep the patient under permissive hypotension.
Okay. You said that his abdominal X-ray there was no swash shadow. What do you expect? What has happened? What do you think?
So yes, we have done an abdominal X-ray showing the patient is having soft tissue. That's possible because of some collection that might be due to some intra-abdominal injury and blood loss as well. We haven't done the ultrasound abdomen or fast scan as yet. So I will be discussing the case with the consultant of my team, and possibly we can do it. Yes.
Dilated
How would you
loops appear.
manage this intra-abdominal collection?
Yeah.
So I will be doing the before transfer. I will be trying to do the ultrasound abdomen in this patient, ultrasound abdomen and pelvis in this patient, as the CT scan is out of order. But
Patient would need
if
laparotomy.
patient will need laparotomy, but we need to shift this patient transfer this patient as soon as possible. But we don't know exactly. We don't know exactly what is the cause of his this abdominal soft tissue absent.
Okay.
What is the injury?
What do you think? What do you want to do about the sole and thigh?
Good.
Sorry, can you please
What
repeat
do you want
it?
to do about the sole and thigh? You're thinking that the patient has a sole and thigh, right?
Yes.
How are you going to manage
That's
that,
right.
doctor?
As we have done an X-ray, lower limb, both lower limbs, and that has revealed the fracture shaft of left femur. I'm going to collate with the orthopedician on call, and he will be doing the fracture reduction. We'll put a Thomas supprint in this patient and reduce supprint the fracture, and provide the analgesia. And I will be taking his advice on the further advice.
Why do you think the patient has metabolic acidosis?
Because patient is having metabolic pH is only 7.32, and patient is having BP of blood pressure of 180, and his hemoglobin has also dropped. So bicarbonate is also low. So I'm suspecting patient is behind the fluids. Patient is hypovolemic, and that's the reason for his metabolic acidosis.
Any other cause? You said the patient had a comorbidity.
Patient is yes, patient is background history of diabetes, and in this case that might be causing his acidosis. Because of that, it's diabetic ketoacidosis.
All right. Okay,
Yeah.
doctor, who would accompany this patient?
I will be accompanying this patient myself, and there will be an anesthetist and ITU registrar from our side. So, but I will be personally accompanying the patient till the transfer is complete, until the transfer is successful.
All right, doctor.
Okay,
Okay,
sir.
thank you so much. You can
Thank you,
send the patient over.
thank you very much, sir. But I would like to summarize.
Yeah, sure.
Before. Okay, we have discussed that we have a 23-year-old male who has a history of RTA, has been brought to our emergency. On examination, he has blood pressure of 180, heart rate of 120, GCS is 14, and his blood has revealed that he is having metabolic acidosis, and HB is only 8. We have done an X-ray, and which has revealed the chest X-ray has revealed the widened mediastinum, and the lower limb X-ray has revealed the left femur fracture. So we're concerned that he might be having great vessel injury, and he needs to be transferred immediately to the center. And you have agreed that you can transfer the patient, and I will be attending. I will be with the patient all the time. Thank you, sir.
All right. Okay. Thank you, doctor. Thank you.
Thank you.
Thank you, ma'am. Thank you.
Thank you so much. Thank you, doctor.
Okay. Thank you. Thank you, ma'am.
Yes, it went good. What do you say?
Yes, ma'am. He did
Compartment
well.
syndrome. Yes, Dr. Abhishek ruled it because I was pointing at the swollen thigh. So compartment syndrome can also lead to acidosis. Diabetes is also
Yes,
one which you mentioned. Yes.
But I have this mentioned, ma'am, because patient is underlying diabetic and patient is hypovolemic and lactate is high.
Yes.
So the possibility of compartment syndrome. About that, I have already said that I will be communicating with the orthopedician. So
yes, look, very interesting. Dr. Suman is saying normally there is no risk with compartment syndrome in femur fracture, but the risk of fat embolism, yes, that is true.
If there's a
Dr. Suman, even if
fracture,
there is a oh, sorry. Okay. I was just asking that he said that there is no risk of compartment syndrome in femur fracture. Even if there is a shaft of femur fracture, then also.
Patient is diabetic as well.
Because
and insulin dependent.
Hello.
Yes, please.
Hello. Yes.
Hello.
Usually, even after fracture femur, the risk of compartment syndrome in thigh is very little, almost nil.
Okay.
It is the most concern is fat embolism syndrome in this thigh fracture or femur.
Dr. Suman,
I think most concerned is cardiac tamponade, that is the widening of the mediastinum.
Yes.
Yeah, you have to discuss more about that because patient is already 100 by means blood pressure is almost acceptable range. So you have to send the patient because he has cardiac tamponade and he may collapse due to this condition. I think so.
Yes. And Dr. Suman, we are more concerned about the compartment syndrome with the patient is having tibia fracture.
Tibia, yeah, leg fracture. Actually, tibia fracture has more. Yeah. In leg fracture, compartment syndrome is risk of compartment syndrome very high. In leg fracture.
Good.
Thank you.
Actually, the fact is, like, whenever the consultant is asking you, Dr. Ishfaq, like, what may be the reason behind it? Okay, so you can tell the first one, like the hypovolemia. Okay, no problem. Second one, diabetic ketoacidosis. But as the patient is having swollen knee, you should tell about compartment syndrome, I think, like maybe at the bottom of the list.
No. Any fracture of the thigh will be swollen thigh. It will be there due to the collection of the blood. In a shaft of femur fracture, there will be at least 1 liter of extravasation of blood. So it will cause swelling. Yeah.
Yes.
It will cause swelling. Any thigh fracture, femur fracture causes about 1 liter of blood outside. Yeah.
More than
that may be a cause of 1 to 1.5 liter. Yes.
Yes, 1.5 liters
up to
loss of blood in the femur fractures on both sides.
Yeah.
And I think examiner will be like looking for this answer, like patients having diabetes and patient is hypovolemic.
Yes.
Yes, examiner
No,
would
no.
look for this answer, but if the fact
Yes.
is compartment syndrome is written in his notes or her note, so you can miss the point. My point
You
is there
can
actually.
add, yes.
Yeah,
Yes, that you are also
that's
right.
it.
And this question came in October 2020 exam.
Yeah.
So
Yes,
widened
ma'am.
mediastinum. So that's why it's good to practice. May
Yeah,
get
actually,
repeated, you don't know.
if examiner will ask you why you are sending it right now, it means what is the emergency, then you have to send first of all about the widened
Yeah.
mediastinum, that is the cardiac tamponade.
Yeah.
Yes.
That is the
That
Otherwise-
most
question is the pulseless foot like vascular consultant station, Dr. Suman, I guess.
yeah,
Yes.
cardiovascular consultant. You are consulting cardiovascular surgeon.
No. Like not in this stem. Like that question is asked, why are you sending the patient right now? What is the urgency? In that case, we can say the further management, definitive management of this hemothorax, definitely, because the patient is having hemothorax. But in case of that stem, like we are
Hemothorax,
referring the
we
patient to
already,
vascular.
Not
Dr.
hemothorax.
Can I
Abhishek, for
finish?
hemothorax,
Can I
for
finish, Dr.
pleural
Suman?
effusion, we
Chest pain.
already put the
We
chest.
have already put the
Chest pain is already there. You only
patient is
sending
having
it
widened mediastinum.
widened. Yes.
That's the reason. That's the concern.
Yes.
Actually, if
Okay,
you see
so
the ATLS or protocol, even you can do it immediately with the needle cardiocentesis.
Wait,
What things?
wait.
Pericardiocentesis.
Starting the timer, and here is the question. Yes, so if you have read and understood, kindly begin your examination.
Okay, I'll enter the examination hall. I'll wash my hand. I'll draw
Yes.
appropriate PPE if it is required. I'll at first I'll try to talk to the patient. The patient is semi-comatose state, so I have to be more careful about that. Like I'll try to introduce myself by giving my identity, and after that I'll ask permission to the patient. Like I'm going to examine her ear, and that
Yes.
looking at her ear, doing some special tests, also looking into her ear with a special instrument that will not cause any difficulty. But if she feels any kind of difficulty, she may tell that. So then I'll gain her consent after describing the examination. And after that, I'll do that examination, if possible, in sitting position, and if the patient doesn't think that she cannot sit, so I can do that in lying position in the couch. So at first I'll inspect both ear, and if there is any evidence of injury mark, any signs of basal skull fracture by right raccoonize, battle signs, if there is any evidence of rhinorrhea, if there is evidence of autoria, and then after doing that, I'll also, if there is any injury mark abrasion over the ear or not. After doing the inspection, I'll go for the palpation of the ear, like I'll check the temperature, local register of temperature over the ear auricle or not, and in the front of the ear or not, in the back of the ear, on both sides, and I'll ask she's having any pain or not. After checking the temperature, I'll slightly check the tenderness, if there is any local tenderness over there or not. I'll be checking different area around the ear and over the ear auricle. And after that, I'll also, then I'll go for the cranial nerve examination of, at first I'll go for 8th cranial nerve examination. I'll ask the patient, like I'll tell her some words by whispering from 15 centimeter distance by blocking his left ear, and doing that from her right side. And if she can hear or not, she can tell me. If she can hear from 15 centimeter distance, I will do that from 60 centimeter distance. And after that, I'll do the same on the left side. And by doing the whisper test, I'll go for the release test. I'll do that, like I'll instruct the patient, like I have a tuning fork in my hand. I'll just bell it right in this way, and it will cause some sound. Then I'll put the base of the tuning fork behind her ear, and whenever she can't hear anything from the behind her ear, so then I'll point that in the front of her ear. Then in the front of her ear, so if she can hear, she can tell me. So I'll do that on both sides. So in this patient, I can find that bone conduction is more than air conduction in either of the ear, I guess, as the patient is having some kind of road traffic accident, some kind of injury over this area. And after that, I'll do the Weber test. I'll tell the patient that I'll put the base of the tuning fork at the front of her forehead. So I'll ask her to tell me that she heard the equally on both sides or not. So in this case, if there is any conductive type of weakness, it may be lateralized to the affected ear. So after doing the whisper test, as the patient is semi-comatose, I cannot do the march on spot test. Then I'll quickly check also the facial nerve. So I'll ask the patient to, without moving the head, to look up actually, if there is any wrinkles over the forehead or not. And then I will ask the patient to close her eyes. I'll try to open it. She will not allow me to do that. And I'll ask the patient to blow her cheeks, and I'll ask the patient to show her teeth. I will ask the patient to clench her neck muscles. And after that, I'll also ask about, I also ask about she has any problems in taste sensation or not. And after that, I also want to check the fifth cranial nerve for this patient. I'll check first sensory function, like I'll check different area, ophthalmic, maxillary, and mandibular area bilaterally on each side, like in the forehead, in the cheeks, and at the base of the mandible region on both sides. And after that, I'll ask the masseter and temporalis muscles strength, like I will ask the patient to clench her jaw muscle. So I'll check the strength of the masseter and temporalis muscle, and I'll also ask the patient to open her mouth against resistance. So I think after doing this type of cranial nerve test, I can also check after doing this, I'll do the autoscope examination for this patient. Like at first I will take the otoscope in a pen holding manner. Like in case of right ear, I will hold it with my right hand. And in case of, I will hold the auricle of the right ear backwards and upwards to straighten the external acoustic meatus. Then I'll go forward with the proper visual guideway and check for any evidence of discharge, swelling, any discharge, wax, foreign body, or any evidence of ruptured tympanic membrane or not, or any evidence of bulging of the tympanic membrane, any evidence of a loss of right reflex, or any evidence of fluid level over there or not, any evidence of hemotympanum over there or not. I'll check that. Any evidence of sclerosis over there or not, I can check for that. And after doing that, I'll also do that in the left ear. And during doing this autoscope examination, I'll rest my hand on the patient's cheek so that my hand can be stable. So after that, I'll just thank the patient, and I'll just thank the patient, and I'll wash my hand.
Yes.
And I'll cover up the patient. Yeah.
All right. Good. Thank you. Can you summarize your examination?
Yes, ma'am. To complete my examination, I would also like to check the other cranial nerves, also do the cerebellar examination, also do the examination of the cervical spine for this patient. So today I have examined a 23 years old girl who is who fell from riding her horse. So on examination, on examination of the ear, actually, she has bleeding from the bleeding from the nose, and on examination, there is no signs of basal skull fracture, but there is bruising of her hair on her face. So on examination and on doing the 7th, 8th, and 5th cranial nerve examination, I found that there is Rini test is negative in the right ear, and
Yes.
the Weber test it just lateralized to the right ear also. And on examination by otoscope, I have seen there may be some bulging of the tympanic membrane, loss of right reflex, and there may be
Yes.
some kind of redness of the tympanic membrane I can see. And
If you have done otoscope, what do you think? This is from which side?
Ma'am, this is from the right side, ma'am.
Yes, why?
And there is evidence of some kind of blood collection in the middle ear,
Yes.
and as there is loss of right reflex, because we can identify it by checking the handle of the malleus actually, ma'am. So
Yes.
handle of the malleus, it starts from the 1 o'clock right upper right part and goes to the lower left part, ma'am, and it stops at the middle at the level of umbo.
Okay.
So we can say yes, ma'am. And there is lack of right reflex of this.
Good.
Of this
Can you tell me what other managements would you do? What other investigations would you ask for? And how should the
for this
be
patient,
managed?
I'd like to
Yes.
do the pure tone audiometry for this patient,
Okay.
and I would also like to do CT scan of the head,
Yes.
if there is any evidence of basal skull fracture or not, and then I would like to discuss it with the MDT, including the neurosurgeon and ENT
Yes.
surgeon.
Okay. And treatment should be?
Treatment should be, ma'am, according to the advice of the neurosurgeon
Yeah.
and ENT surgeon for the basal skull fracture. I think if the patient is stable enough, at first we can just admit him in the SDU setting, and we can repeatedly do the monitoring of the patient, and if any surgical treatment is required for this patient, so that can be done by the ENT surgeon and neurosurgeon, I guess.
Very good. Very good. Still had 10 seconds left. All right. Okay. Since this was a case of head injury, so it was clear.
Yeah,
Diagnosis was evident. Thank you.
yes, ma'am. Right-sided conductive type of deafness with hemotympano.
Good. Antibiotics? Maybe not.
Maybe it's not given as there is no sign of infection.
No. So until unless indicated, you don't give antibiotics in the West. Good. So, yes. Feedback. How did you feel?
Sorry, ma'am?
How was your feeling attempting this station? I'm sure you have attempted it before.
Actually, whenever I practice this station, then I just did it actually according to the ear examination.
Yes.
Because what we do
That's
in the
what
examination,
it comes.
first look it, at first look at it, then we can do the cranial nerve examination,
Yes.
right? So, two things we can.
And then they'll ask you as well, which two nerves can you examine together?
Yes, ma'am. The 7th and 8th.
Yes. Yes. Right. Yes. Anyone else want to add anything? Yes, please.
I have a question. Like after 7th, 8th nerve examination, if time permits, what other nerves we can do?
We can examine 7, 8, 5.
Or we just leave. I have no idea.
We can examine the olfactory optic oculomotor also, because the head neck region injury, that is also relevant if there is any evidence of other.
Yes, if time allows, but here it was like exclusively ear.
Yes. Maybe 7th and 8th is itself will take too much time.
But Dr. Abhishek completed within the time.
There are 3 steps, right, brother? Like first one is anterior cranial fossa tumor with bitemporal hemianopy, right? So in that case, we'll have to check 1, 2, 3, 4, 6. 1, 2, 3, 4, 6 first. Then we can do the. After that, we have to. Then we can do the rest. And in case of in case of first one, except the 7, 8, we can do the all actually, and we can also ignore the 9, 10th, 11, 12 if the time doesn't permit. But in case of this ear injury, we will have to first check the 7th and 8th. Then if it is relevant, we can go for the 5. And in case of that, the last one, like we can find the anosmia and also some visual problem. Also, there is some what is the other finding, like defect in lateral gaze, something like that. So in that case, we have to check first that 1, 2, 3, 4, 6 first, then we'll go for the AMTS.
Yes.
Okay, then AMTS, yes.
Good. Yes, Dr.
Okay,
Ulfat.
thank you.
She has a question. Yes.
Ma'am, my question is, first, are we going to go first for the AMTS or then we go for the cranial nerve, because the patient is comatose, semi-comatose, right? So should we not go for, or shouldn't we like conclude that yes, the patient will be able to consent for the examination? So should we go for the AMTS first and then the cranial nerve examination, or what? If Dr. Abhishek,
I have a suggestion for
what do you
this,
think?
like Dr. Ulfat, the FTA
Yeah.
will say you do the relevant cranial nerve examination
Yes.
and also check his or her mental status.
Yes.
Whichever is
Oh, they say
expected
it.
first, you can
It
go
will
for
be
first.
mentioned.
They'll directly say it. They'll directly
Yes.
mention it.
Yes.
That
Yes,
Yes. They will
in
tell
that
you.
case, we are going. In that case, ma'am, we will go first for the cranial nerve examination. Then we'll go
Yes.
for the AMTS.
Yes.
We don't
AMTS,
have to
yeah.
go for the MMSE.
No.
MMSE,
No.
yes.
No.
No.
And here again, I didn't ask you to check the mental status. So
Yeah.
Okay.
Dr. Abhishek didn't do it.
Yes,
Yeah.
I'm
yes.
sure you noticed. Yes.
Yes, but ma'am, are we going to mention it later on that, you know, I would like to do this,
You
and
can
also
say I can complete my examination with this.
yes.
You can add if you want,
Okay.
but it's not must. If it would be, then they will mention it. Very
All
clearly
right.
they will say it, what they want you to do. Yes?
Okay,
Yep.
because ma'am, if you remember, Dr. Asra once said that, you know, this station had come in her exam,
Yeah.
and she has said the whole of the MMS and the AMTS, and then done the. Do you all remember, or did I hear it wrong? If either of you could remember, perhaps.
I didn't get to record it, so I forgot what
Yes,
she
yes,
said.
I
I'm
can remember
sorry.
it.
Ask them.
Yes.
If
You
someone
can
could
remember the
please
points.
explain me
The
that
points
thing.
are,
Yes.
yeah.
No, it's
She was
okay,
like
ma'am.
telling I tell the whole points of MMS, all the 30 points, something she was
Yes,
saying,
he did
and
say
the
that.
examiner was impressed or something. But I
I
don't know whether
know.
we
Yes.
should.
If time allows, and besides,
Practice, ma'am.
yes.
She said, Dr. Ulfat, actually, she said first of all, she has done have done the MMSE. AMTS
AMTS.
first. Yes,
Mhm.
but
Yes.
she thought that if she would do the MMSE one first, she would get more marks. Okay. So after that, she just spontaneously told about the MMSE one. She was not asked actually, but she told that I want to do MMSE. I'll check this. So most of the time, people says that whenever you want to do the MMSE one, the examiner just say it consider. But to be in the safe side, I would suggest that it has a good mnemonic like oral. You can do that or like doing it practice like 4 to 5 days. It will just cover it. That's it.
Yeah,
Then
they
you have to.
have a sheet.
Yes.
They have
Yeah.
MMSC has a sheet of questions and everything. There is 30
Yes.
questionnaire sheet. Yes.
And then
Yes,
you have
actually,
to
that is
practice it.
not 30 question, like 5 are really
No, not 30 question, 5
analyzed.
compartments,
Yes.
but yes, they are tail
Yeah.
questions. Tail questions.
Yeah.
Yes.
Questions, yeah.
Thank you, everyone.
Thank you
Thank
so
you,
much.
ma'am. Thank you,
Thank you,
Dr.
Dr.
Ravi.
Abhishek. Should we move on? Dr. Mohammed Al Tahir. Yes. Question. Right. So if you have read and understood, kindly tell me which part is this of the limb, upper limb?
Okay. This is a right. No, no, yeah, left. Cubital fossa.
Okay. Cubital fossa. Can you tell me the boundaries of cubital fossa?
Yeah. For the boundary, we have brachioradialis.
Yes, laterally.
Laterally,
Yes.
yeah. The medially pronator teres.
Very good.
Then superiorly, we have the imaginary line that runs between the medial and lateral epicondyli.
Very good. Yes. And the roof and the floor?
For the floor, okay, for the roof, we have the fascia
Yes,
and
the fascia.
subcutaneous tissue. Yeah.
And the floor is by brachialis.
Yeah, and the floor, of course, the muscle of the brachialis
Yes.
muscle.
Can you identify structures from A to F, H?
Okay, from A,
Yes.
should I go directly? I think.
Yes.
Okay. A will be medial nerve, right?
Yes, left median nerve. B, please.
Okay.
B is muscle.
B is that's medially, that's pronator teres.
Yes, left pronator teres muscle. And C, please.
C is vein.
No, ulnar artery. Left ulnar
Ulnar
artery.
artery, that's the artery.
Yes.
Okay.
Yes. D, please. D is
Okay, D from lateral side.
yes.
That is the cephalic vein.
Very good. And then E, please.
E with the brachial artery.
Okay. And F.
F, where is F?
Yes.
F
is
with
here.
the tendon of the brachial.
Yes.
Brachialis.
And G.
G will be brachioradialis.
Yes. And H.
H will be ulnar artery. No, sorry. Radial artery.
Okay. Can you also tell me what is the origin, insertion, and action of G muscle? Where is it?
G.
Yes.
Yeah,
G is yes.
brachioradialis.
Yes.
So
Brachioradialis muscle.
yeah, I think it originates from the distal part on lateral aspect of the distal part of the humerus.
From
Just,
lateral supracondylar ridge of the humerus.
yeah,
Yes.
yeah, and it inserted on the radial bone.
On the base of the sterloid process of radius. Yes.
Yeah.
What is the action? What does it do?
Yeah, action first, it helps in flexion of elbow.
Flexion and semi-pronation of elbow.
Yes.
Yes. What does it? Is it innervated by which nerve?
Okay. It's innervated by radial nerve.
Yes. Posterior.
Six.
Yes. Yes. Okay. Can you also tell me what are the humeral attachment of flexor, common flexor and extensor muscles of the forearm?
Come again.
Can you tell me what is the humeral attachment of common flexor and common extensor tendons of the forearm?
So the common flexor origin from the common flexor origin, that's along the medial and epicondyle.
Yes.
Whereby the common extensor originate from behind the lateral epicondyle.
From the anterior aspect of the lateral epicondyle.
Yeah.
Okay, good. Can you tell me, please, about what is annular ligament?
Annular ligament is the ligament that wind around the head of radius.
Okay, can you tell me what layers protects the brachial artery when blood is drawn from the median cubital fossa?
What layers, right?
Yes,
so starting from superficial, we have the skin, we have the subcutaneous tissue and fascia. Then we after that, then we have the deep fascia. Then before we have the cubital fossa, where the brachial artery is located.
It's the bicipital epineurosis, which lies between the yes. So that is the one which protects. Okay. Can you also tell me what is the function of anconeus muscle?
I've forgotten. I think it also helps in spination.
Okay, is the ulnar nerve medial or lateral to the ulnar artery at rest?
Come again?
Ulnar nerve, is it medial or lateral to the ulnar artery at rest?
Oh, at rest, yes.
Yes.
Yes. Yes.
Medial or lateral?
Ulnar nerve is ulnar to ulnar artery, so it's a medial.
Okay, at the wrist, which tendon lies lateral or radial to the median nerve?
Which what?
Tendon. Which tendon lies lateral to the median nerve?
At the wrist.
Yes.
Yeah. So we have a tendon of the flexor cardioradialis.
Radialis. Very good. Okay. Can you please identify these structures? In picture A, 1, 2, 3, and in picture B also A, B, C, D, E.
Okay.
What is
so,
one?
One will be the tendon of the tendon cardioradialis. Then 2 will be palmaris longus. Then 3 will be tendon of the flexor cardioradialis. Hello.
Okay. Yes. One is brachioradialis.
Okay.
And then right. I'm looking at the right. Okay. Then what is 2?
I said 2 is the tendon of the palmaris longus.
Okay, we'll see. And then 3?
3 is the tendon of the flexor cardioradialis.
All right. Here in picture B, A, B, C, D, E.
Okay. In picture B.
Yes.
Okay. Yeah. In picture B, A will be the tendon of the flexor cardioradialis. In that way.
Okay.
Then B is still showing the tendon of the palmaris longus, if I'm correct. Then D is showing superficial vein. That's radial vein, superficial vein. That's D. Then E is showing a cephalic vein, and C is showing a basilic vein.
All right, we'll discuss this. Can you tell me at position E, what is the name of the vessel which is cannulated?
That's the medial vein.
Okay. Can you tell me the compartments in the forearm? What are the muscles and what is their nerve supply?
Okay. For forearm, we have the anterior compartment and the posterior compartment.
Yes.
So in the anterior compartment,
so anterior is also 2, anterior superficial.
Yeah, we have the superficial and the deep.
Yes.
So, and for superficial muscles, of course, they include the palmaris longus, brachioradialis muscle. Then we have flexor cardialis on superficialis. Then for the deep one, we have flexor superficialis. Sorry, not carpi. Then we also have flexor carpi ulnaris and flexor carpi radialis. Then for the deep, we have flexor profundus. We also have flexor pollicis longus. We also have what else? Okay, we also have pronator teres. We also have supinator. Okay. Then yeah.
These muscles are innervated by which nerve?
Yeah, for the muscles, we have for most of the muscles of the anterior compartment innervated by medial nerve.
Yes.
So and then we have a lateral half of a flexor digitorum profundus. Then for the muscles of the medial compartment or medial part, which is innervated by ulnar nerve, which are medial half of flexor digitorum profundus and flexor carpi ulnaris.
Okay. And the posterior compartment is supplied by the radial nerve?
By the radial nerve. And
yes.
The muscles in posterior compartment, they are, of course, we have a extensor carpi radialis brevis and longus. we have extensor carpi ulnaris, we have extensor digitorium, extensor digit minimi, then we have
okay.
extensor indices.
Can you tell me what are the muscles which are responsible for supination and pronation at the elbow?
At the elbow, yeah, for pronation, we have a pronator teres.
Yes.
Then for supination, we have maybe brachioradialis and acroneus, I think.
For supination, it's biceps and supinator, and for pronation,
Yeah.
it's pronator teres and pronator quadratus.
Yes.
Okay, now we'll do, okay, can you tell me what is the dermatome which is labeled by A, B, and C?
Okay, dermatome label A will be C6. Then dermatome label B will be C8. Yeah.
Okay,
okay,
dermatome.
okay. C will be T1.
A is C6.
Yeah.
A is C6.
Yeah.
B is C8.
Yeah, and C is T1.
C is T1.
T1. Yeah.
T is T1, T2. Above, here above is T2, but here is T1. Okay, which dermatome is supplied by, which nerve supplies dermatome at C, at position D?
That's the musculocutaneous nerve.
Which cutaneous nerve supplies, okay.
Yeah, that cutaneous part of the musculocutaneous nerve.
All right, okay. Lateral cutaneous nerve of the forearm.
Yeah.
Yeah. Okay, good. All right. Those three muscles that that I asked you. So tell me again, please. One is.
Yeah, you said one is brachioradialis, right?
No, sorry, that was wrong. It's flexor carpi radialis tendon.
Oh, that means I was right. Okay.
You were right. Yes.
Okay, flexor carpi radialis.
And then two.
Palmaris longus.
Flexor digitum superficialis.
Oh, flexor digitum. Okay.
And
flexor carpi ulnaris.
Flexor carpi ulnaris. Good. Yes. Brachioradialis is here in this area. I got mixed up. I was looking at the answers. And I'm sorry I mixed up. That's why I thought I'll not waste your more time. We'll discuss this at the end. Okay, good. Thank you. Right, one more thing. You told me everything, right? Muscles, function of Anconius you wanted to know.
Yes.
It's a small muscle that originates from the lateral epicondyle and inserts into olecranon process. And it aids in extension of the elbow and stabilizes
like
the joint.
Triceps, yeah.
Yeah.
Same nerve supply.
Yes. So its basically function is extension of the elbow and stabilization of the elbow joint.
Okay.
Yeah. That's it.
That book's question, right, ma'am?
Yeah.
Or,
yeah. Exactly.
Yeah.
Thank you so much. Yes.